A 55-year-old male presents to the emergency department with a 3-day history of progressively worsening shortness of breath and pleuritic chest pain. He has a history of hypertension and is a smoker. On examination, he appears diaphoretic and in distress. His vital signs are as follows. Blood pressure 160/90ths of a millimeter of mercury. Heart rate 110 bpm. Respiratory rate 28 per minute. Oxygen saturation 88% on room air. Chest auscultation reveals decreased breath sounds on the right side. What is the most likely diagnosis for this patient? A. Acute myocardial infarction. B. Pneumonia. C. Pulmonary embolism. D. Aortic dissection. E. Tension pneumothorax. Explanation. This patient's presentation with sudden onset shortness of breath, pleuritic chest pain, and decreased breath sounds on one side is highly concerning for a tension pneumothorax, a life-threatening condition. Tension pneumothorax can cause mediastinal shift and compromise cardiovascular function, leading to hypotension and tachycardia. Prompt needle decompression or chest tube placement is required. A 62-year-old woman with a history of type 2 diabetes and chronic kidney disease presents with a 2-week history of worsening lower extremity edema and fatigue. On examination, she is noted to have bilateral pitting edema extending up to her thighs. Her blood pressure is 160/90ths of a millimeter of mercury, and her heart rate is 80 bpm. Laboratory results reveal elevated serum creatinine and hyperkalemia. What is the most likely cause of her symptoms and laboratory findings? A. Diabetic nephropathy. B. Heart failure. C. Nephrotic syndrome. D. Acute kidney injury. E. Hypertensive emergency explanation. This patient's presentation with bilateral lower extremity edema, hypertension, and elevated serum creatinine is highly suggestive of heart failure with preserved ejection fraction, HFpEF, also known as diastolic heart failure. HFpEF often occurs in patients with comorbid conditions such as diabetes and chronic kidney disease. It is associated with fluid retention, leading to edema, and can result in elevated serum creatinine due to decreased renal perfusion. A 45-year-old male presents with a 2-week history of progressively worsening jaundice, dark urine, and clay-colored stools. He denies any abdominal pain but reports significant weight loss over the past few months. On examination, he is icteric, with hepatomegaly noted on palpation. Laboratory tests reveal elevated liver enzymes, total bilirubin, and CA19-9 levels. What is the most likely diagnosis in this patient? A. Alcoholic liver disease. B. Hemochromatosis. C. Pancreatic cancer. D. Autoimmune hepatitis. E. Primary biliary cholangitis. Explanation. This patient's presentation with painless jaundice, hepatomegaly, and elevated CA19-9 levels is highly suggestive of pancreatic cancer, particularly carcinoma of the head of the pancreas. This malignancy often presents late and can cause obstructive jaundice due to compression of the common bile duct, leading to elevated bilirubin levels and clay-colored stools. A 30-year-old woman presents with a sudden severe headache that she describes as the worst headache of her life. She also complains of neck stiffness and vomiting. On examination, she has photophobia, and there is nuchal rigidity. A non-contrast head CT scan is performed and shows subarachnoid hemorrhage, SAH. What is the most likely cause of her symptoms? A. Migraine. B. Tension-type headache. C. Intracerebral hemorrhage. D. Aneurysmal subarachnoid hemorrhage. E. Meningitis. Explanation. The sudden onset of the worst headache of her life, neck stiffness, vomiting, and photophobia in this patient strongly suggests an aneurysmal subarachnoid hemorrhage, ASA. This is a medical emergency, and prompt evaluation and treatment, such as neurosurgical intervention to secure the aneurysm, are necessary. A 60-year-old man with a history of heavy alcohol use presents with confusion, abdominal pain, and vomiting. On examination, he has asterixis, flapping tremor, and abdominal tenderness. Laboratory tests show elevated serum ammonia levels and deranged liver function tests. What is the most likely diagnosis for this patient? A. alcoholic hepatitis B, acute pancreatitis C, hepatic encephalopathy D, acute cholecystitis E, peritonitis. Explanation: this patient's presentation with confusion, asterixis, and elevated serum ammonia levels is consistent with hepatic encephalopathy. In the context of heavy alcohol use, this is most likely due to alcoholic liver disease, specifically alcoholic hepatitis. It's important to address alcohol cessation and provide supportive care for liver function. A 55-year-old obese woman with a history of hypertension and type 2 diabetes presents with progressive bilateral lower extremity weakness and difficulty walking. On examination, there is bilateral lower extremity weakness, decreased sensation in a stocking glove distribution, and absent ankle reflexes. What is the most likely diagnosis for this patient? A. Guillain-Barré syndrome. B. Diabetic neuropathy. C. Lumbar disc herniation. D. Multiple sclerosis. E. Diabetic myelopathy. Explanation: this patient's presentation with bilateral lower extremity weakness, sensory deficits in a stocking glove distribution, and absent ankle reflexes is consistent with diabetic myelopathy. This is a rare complication of diabetes that affects the spinal cord and can lead to progressive weakness and sensory changes in the lower extremities. Tight glycemic control is crucial in managing diabetic myelopathy. A 45-year-old woman presents with a history of chronic diarrhea, fatigue, and unintentional weight loss. She has noticed blood in her stools occasionally. Physical examination reveals pallor, digital clubbing, and a systolic ejection murmur heard best at the left sternal border. Laboratory tests show microcytic anemia and an elevated erythrocyte sedimentation rate, ESR. What is the most likely diagnosis for this patient? A. Celiac disease. B. Inflammatory bowel disease, Crohn's disease or ulcerative colitis. C. Colorectal cancer. D. Gastrointestinal bleeding due to NSAID use. E. Infectious gastroenteritis. Explanation: this patient's presentation with chronic diarrhea, weight loss, microcytic anemia, clubbing, and an elevated ESR is suggestive of inflammatory bowel disease, IBD, specifically Crohn's disease. The digital clubbing and systolic murmur suggest possible complications such as nutritional deficiencies and cardiac involvement often seen in patients with IBD. A 65-year-old man with a history of coronary artery disease presents with sudden onset severe chest pain radiating to the left arm. He is diaphoretic and appears anxious. His blood pressure is 90/60ths of a millimeter of mercury, and heart rate is 110 bpm. An ECG shows ST segment elevation in the anterior precordial leads. What is the most likely diagnosis for this patient? A. Acute myocardial infarction. B. Stable angina. C. Aortic dissection. D. Pericarditis. E. Gastroesophageal reflux disease, GERD. Explanation: this patient's presentation with sudden onset severe chest pain, diaphoresis, and ST segment elevation on ECG is highly suggestive of an acute myocardial infarction, AMI, specifically an ST segment elevation myocardial infarction, STEMI. Rapid reperfusion therapy, such as percutaneous coronary intervention, PCI, or thrombolytic therapy, is required urgently to restore blood flow to the affected coronary artery. A 30-year-old woman presents with recurrent episodes of palpitations, sweating, and a sensation of impending doom. These episodes occur suddenly and last for a few minutes. She denies any chest pain or shortness of breath. Physical examination and routine ECG during clinic visits are unremarkable. What is the most likely diagnosis for this patient? A. Panic disorder. B. Atrial fibrillation. C. Paroxysmal supraventricular tachycardia, PSVT. D. Ventricular tachycardia. E. Hyperthyroidism. Explanation: this patient's recurrent episodes of sudden palpitations, sweating, and a sense of impending doom lasting a few minutes are typical of paroxysmal supraventricular tachycardia, PSVT. PSVT is a benign arrhythmia, often involving the atrioventricular AV node, and can be triggered by various factors. An electrophysiological study may be needed for further evaluation, and treatment options, such as catheter ablation, may be considered. A 60-year-old man presents with a 6-month history of progressive cognitive decline, personality changes, and difficulty with motor coordination. He has a history of heavy alcohol use. On examination, he has a wide-based gait, dysarthria, and intention tremor. There are also signs of ophthalmoplegia, difficulty moving his eyes. What is the most likely diagnosis for this patient? A. Alzheimer's disease. B. Frontotemporal dementia. C. Huntington's disease. D. Wernicke-Korsakoff syndrome. E. Multiple sclerosis. Explanation: this patient's presentation with cognitive decline, personality changes, ataxia, wide-based gait, dysarthria, and ophthalmoplegia is consistent with Wernicke-Korsakoff syndrome, WEAKS, which is typically caused by thiamine, vitamin B1, deficiency, often seen in individuals with heavy alcohol use. The cognitive impairment seen in WEAKS includes both the acute phase, Wernicke's encephalopathy, and the chronic phase, Korsakoff syndrome. Thiamine replacement is essential for treatment and may prevent further neurological deterioration.